The patient is positioned in a supine position on a radiolucent table, and general anesthesia is induced and supplemented with a caudal block for postoperative pain management. The operative extremity is exsanguinated. A 2 cm longitudinal incision is made just distal to where the tibialis anterior tendon can be palpated on the dorsum of the foot. There is commonly a moderately sized superficial vein encountered in the subcutaneous tissues. This should be preserved throughout the dissection. Sharp dissection is then carried down to the tendon sheath, which is incised in line with the tendon fibers. The tendon is isolated circumferentially with a Graham hook and released from its insertion point, working from proximal to distal, with care to preserve as much length as possible without damaging the underlying periosteum and cartilage. Once freed adequately, the tendon is prepared using a strong, non-resorbable suture, as Keith needles are used simultaneously to weave a Bunnell-type stitch through the distal aspect of the tendon. The center of the lateral cuneiform is identified using fluoroscopy. This is typically in line with the third metatarsal. A 1 cm incision is made in the overlying skin, and dissection is carried down onto the periosteum. A Keith needle is placed in the center of the cuneiform and confirmed with fluoroscopy. A drill hole is then made using a 4.8 mm hand drill. Use of a hand drill provides improved tactile sense while drilling the soft cartilaginous bone and plantar periosteum, and prevents undue damage to the plantar nerves. A curette is used to remove loose bone and cartilage from the drill hole and confirmed with fluoroscopy. And a cruciate-type incision is made in the periosteum to ensure that no periosteum is pulled into the bony tunnel during tendon passage. A blunt hemostat is used to create a subcutaneous path from the lateral incision to the medial wound. The tibialis anterior tendon is retrieved and pulled through to the lateral aspect of the foot. Tenotomy scissors are then used to free the tendon from surrounding tissues, including the vinculi at the proximal aspect. 1 or 2 millimeters of the distalmost edge of the inferior extensor retinaculum is also released to ensure that the tendon follows a smooth, straight path across the ankle. The suture ends are once again threaded onto Keith needles, which are passed through the bony tunnel of the lateral cuneiform and partially out of the plantar surface of the foot. A piece of non-stick gauze, foam square, and button are placed over the needles, which are then pulled completely through the skin. The sutures are tensioned over the button while holding the foot in maximal abduction and dorsiflexion. If less than 10 degrees of dorsiflexion is obtained, a percutaneous Achilles tenotomy should be performed prior to final suture tensioning. The operative extremity is then placed in a plaster long leg cast for 6 weeks. At that point, the cast is removed, sutures are cut, and the button is removed, and the patient is allowed to advance their activity as tolerated without need for additional bracing or restriction.